these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold
these truths. We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Welcome back, everybody. We're going to have another conversation about AI, but this time specified on healthcare. As my guest here with me, Dr. Brian Miller. Thanks for being on.
Thank you for having me.
Might point out, the experience in healthcare, however you enter the healthcare system, it often sucks. And so how much worse can it get? Some people might ask with wait times and just general experiences. And so we're going to have a conversation today about new technologies, specifically AI, how much that might help the patient experience, and of course some of the obstacles to getting that point. So Brian, thanks for being with us.
Thank you for having me. You're right, the patient experience is sort of terrible right now. So you go to the doctor after you've already filled out the forms online about your medical history, and then you sit in the waiting room and they give you papers and they say, by the way, can you fill out the forms about those medical history? And then they call you back into the room and they say, so can you tell me about your medical history? And then after the MA leaves and the doctor comes in.
By the way, that always happens at 5 a.m.
Yes.
When you're inpatient. I have a lot of experience being inpatient.
Oh, yeah.
And so It's always 5 a.m. rounds. So who are you again? I'm like, come on.
You're like, I was asleep.
I was asleep. I don't sleep very much, but thank you for waking me up from that very little sleep I get because I was just blown up by a bomb. But I have a very unique inpatient experience.
Right.
But anyway.
No, but the inpatient experience is just as bad, right? Because they check your vitals every 4 hours. They wake you up. They stab you in the arm to draw your labs before, hopefully, the doctor comes. Then the doctor and nurses come and see you, and it's a whole swarm of people. You don't know who they are, right? Yeah. You don't have access to your own records. They tell you what's going on, and then, later in the day, stuff randomly happens. Yeah. It's disorganized.
Yeah. Or it seems that way to the patient. Whether it is that way, it probably depends on the hospital. Let's at least give some space here for, good. There's great hospitals out there. I'm sure great experiences too. I've a mix, and I've been in hospitals a lot. And sometimes it's great, sometimes it's fantastic. You know exactly what you're doing there, and other times not. But it doesn't really matter, right? There's room for improvement. I think. Right, I think is the point.
There are good facilities, there are bad facilities, good doctors, bad doctors. But the point is that we are operating in a paper-driven manual process. It's like medical care right now is a 747 with no autopilot and no digital display.
Well, so that's true, a lot of paperwork, but at the same time, electronic health records are a thing too, mandated through Obamacare, and everybody complains about that also. So, I guess the question becomes what the heck are we supposed to do? Because the paper's not working, the electronic health records aren't working for doctors, especially who don't like having to fill those out the way they do have to fill them out. I mean, and also give us a little bit about your background so the audience knows who we're talking to. And how you got interested in this.
I guess you'd say I'm a recovered bureaucrat. So in addition to being a practicing hospitalist at Hopkins, I'm a non-resident fellow at AEI, and I worked for 4 regulatory agencies. So I worked at the FDA, the FCC, the FTC, and CMS.
What's a hospitalist?
So a hospitalist is internal medicine, but inpatient only.
Okay. So
we care for patients on the medical floors. We do 12-hour shifts. Okay. You have a floor, and it's yours.
I see. Is specializing in anything in particular? It's just general care?
Everything. Okay. So pneumonia, heart failure,
whatever. For people. You're the one waking me up at 5 a.m.
Yes.
Oh, thanks.
Yes,
okay.
I'm the guy waking you up in the morning.
You're doing the rounds, waking me up. And how did you get interested in this? I mean, what's like an aha moment? I mean, AI, the conversation surrounding AI isn't that old.
Yeah, it's not old. I got interested in this actually as a med student because I remember a patient asked to be discharged by noon. When I was a med student, we tried to be patient-centric, and of course they got discharged at 5 o'clock. And I remember thinking, well, this is wrong. And they left the building with a stack of paper. In clinic, I remember as a med student, the attending, great doc, really detail-oriented, nice, and funny. 2 hours late to every appointment, 2 hours. And I asked them, and they said, this is how the system works. My thought is, we can do better.
Yeah.
And so technology is the one chance we have, right? So we're in an industry, high barriers to entry. It's hard to build facilities. There's a lot of technology. There's a lot of training. There's a lot of regulation. Technology and automation are one of the things that could free us.
Yeah, no, that's true. I mean, it frees us in quite a few industries. The healthcare industry is tougher for one of the reasons you stated. I mean, it's highly regulated, and there's kind of institutional barriers, right? I mean, just avoiding change, avoiding your comfort level with certain practices, whatever the case may be. But I mean, so if we're talking about AI, let's talk specifically about AI, and I guess let's define what we mean by AI. We did a pretty in-depth podcast on AI that I think we released a couple weeks ago. By the time this is released, maybe it's a few weeks ago. My very loyal listeners who give me 5 stars every single time they listen will remember it. And if you're not one of those listeners who's giving me 5 stars, I don't even know who you are. I mean, I just can't even believe that it feels like a betrayal. There's a lot of work we put into this podcast. Anyway, AI is defined by some kind of program that takes data in, takes those inputs in, goes through a machine learning process, and becomes able to sort of think kind of in a way, or at least predict what human behavior would be a more exact way of saying what AI is. Healthcare is an interesting place to do that, right? Maybe you could tell AI, give AI the task of, hey, solve Alzheimer's. Here's all the data. Solve Alzheimer's, or just figure out how to take care of a patient who has this kind of these whatever it is. How does it look like in your mind?
I would say there are 3 uses. The first is the painful stuff that we don't want to. I call it automation of the mundane. So it's all the administrative processes that kill doctors and patients, right? So prior authorization, imagine if the information were automatically extracted from the electronic health record and sent to the insurance company for the first layer of review, and you got a real-time decision.
That would be nice.
Yeah, that would
seem
be
like
nice.
that hard. Is that even AI? It could just be like a clever program, right? It
Could be
shouldn't
AI.
be that high. It shouldn't be that
It should
hard.
not be. Other things like automatically recording and transcribing notes and putting it in a form. So then, like, instead of you're talking with because the joke is you go see like your primary care doctor, and that you're not actually seeing your primary care doctor. You're seeing the computer, right? And you see your primary care doctor for 2. Yeah, my primary care doctor is great. I love her. She's one of the best doctors I've met. But she's stuck. She's stuck at the computer. Wouldn't it be great if she had a conversation, examined me, looked at labs, and then just the note automatically was there for her to proofread?
Right. Yeah, that'd be nice. I mean, that's pretty basic technology. Right? It should be,
but it's not.
So is anybody creating kind of, I guess, any of this stuff and trying to sell it to hospitals?
Yeah, there are some companies like on the note-taking working on the sort of natural language processing.
Yeah.
The second, I would say, use, and there are 3. The second is sort of augmentation. So it's taking that human capital and making it more efficient.
Right.
So like looking at the CT scan, let's say you come in, you have chest pain, we're worried you have a blood clot, do a CT scan, automatically have technology look at it, or AI, and say, this is likely a PE, or this is not. Have the radiologist review.
Yeah. Yeah, I mean, you wouldn't think that'd be that hard. And is that, again, that's a little bit more advanced than, say, just automating notes.
Exactly.
And how close do you think we really are to that point?
I'd say it's starting now. It'll probably take 5 to 10 years, but that could really, imagine instead of looking at 5 scans, you could look at 20 in the same time period.
Yeah. What do you think doctors' reactions would be to a program that purported to be able to do that?
Well, depends upon the doctor. I think some doctors are going to be threatened, but I don't think they should be.
Yeah. Well, in theory, it doesn't take away the doctor's job. I'm like, as a patient, I don't want just an AI opinion. I would want both, but maybe that the doctor can come up with an opinion much quicker,
more efficiently,
right?
Safer, and then actually spend more time talking with you,
right,
and helping you figure out what your choices are, rather than looking stuff up, in front of you while they're on the computer and you're sitting there waiting. Calling
colleagues, like, because there's some problems, like, we've all seen the show House, right? And the premise of that show is he's always solving some really difficult, like, medical dilemma. And I'm sure that happens a lot in medicine, and you do that research by pulling up research papers and calling other colleagues. Like, there's a lot of work that goes into that, but perhaps that work is somewhere all in a database that an AI bot can search rather quickly.
Exactly, and suggest. And doesn't have to be definitive, but could suggest that diagnosis or suggest that course of treatment.
Yeah,
and so that
tells you why and like what's it referencing. It's like, oh, well, that does make sense. I guess.
And it's more efficient. Right. So it allows the doctor to spend more time being a doctor. And even for something like pathology, right? You know, the guy running the lab. Well, if the machine, for example, let's say it sliced the tissue, mounted on a slide, looked at it, suggested diagnoses with a certain degree of performance.
Yeah.
Then you're reviewing the suggested diagnoses and working on picking the right assay, as opposed to slicing the tissue, mounting it, et cetera.
So why isn't Johns Hopkins does a lot of really interesting research. They got all these crazy labs doing all sorts of cool things. Not even to do with healthcare necessarily. Like, what are they? Is that institution looking at this at all?
Absolutely.
Yeah. So is that where we can expect the next, like, what's the doctor from Star Trek called? Like the hologram.
The doctor? Hologram from Star Trek Voyager.
Yeah.
I think that'll come out of Silicon Valley. It's probably decades away, but like that would be great.
Decades. You think
decades?
Decades, like a real life, like. Yeah, a doctor who can talk to you, assess you, all of that. I don't know that it's decades away. There's AI bots right now, like tricking people into thinking they're human rather easily. Now a doctor, that's different.
That's different.
Yeah, that's
bedside
quite
manner,
different.
Conversation, and knowledge, and human interface. So the machine-human interface is a huge challenge.
Yeah.
And that gets to sort of the third use of AI, which is replacing the human capital. And in some cases, it will, but we shouldn't be threatened because we're always going to be needed.
Mm-hmm. Yeah, it's hard for me to ever imagine a day where I don't want a doctor overseeing whatever. I mean, they already use robots, right? You know, that's what surgeries.
Da Vinci surgery,
right? I mean, it's vastly different than surgery used to be.
And we're not in the yet. We're probably 50 years away from the movie. Have you seen The Arrival?
Yeah.
The automated surgical bay where it scans you and then automatically injects you and automatically does surgery. That's like decades and decades away.
Yeah, that seems like quite a leap, right? I mean,
it is quite a leap.
Yeah, I'm not even sure. You know, it's total sci-fi.
But it will probably get there in our lifetime, actually.
Yeah, I mean, how? Like what would that? I mean, because I had this conversation yesterday about I did a podcast on intelligent design. Right. And kind of an interesting point that comes up in that conversation is, the people who are opposed to intelligent design. I'm not curious, I don't know sure where you are on that question. I think intelligent design is probably the most plausible explanation for us. And I think if you're going to counter it, you have to be able to develop some kind of theory as to how this accidental evolutionary natural selection happened, and that actually doesn't exist. Not a really strong explanation anyway. And at a certain point, we know enough about what's it can at least be theorized to say how it would happen. That's why I ask. Like, I'm sure we can imagine how that healthcare pod would happen, like how it would scan, how it would do things. I guess, what does it have, like a built-in MRI? Like, how do we, like, that's what I mean. Like, what are we talking about? Yeah, it has
built-in imaging. So something like that though, it may do procedures, it may diagnose, but you still, to some degree, need a human. Yeah. Right? Because to make decisions for simple things, fine. Like a computer can and probably will replace some specific tasks for different specialties. Yeah. Right? And that's okay because there are higher level tasks that you need the human brain. Right. And that will be a long time before that gets replaced.
Yeah, and assess different factors, because maybe you could create a machine like that, like just for gunshot wounds. Right. Like you deploy it into a war zone and because you already know a few things, like you're dealing with males between these ages. They're generally healthy except for the whole gunshot wound thing. Right. And you could imagine a machine being able to quickly at least get the initial stitches in, and stabilize before a doctor can get there. That seems like how it would start. I don't know. I'm just
probably it would start in a more defined area rather than just being sort of general diagnosis and treatment. Yeah. And so that's what we're seeing right now, right? Like automated diagnosis of suspect moles when you have a skin exam. Automated diagnosis in radiology, it's suggesting potential diagnoses like, there might be a tumor there might be a clot there.
So, how much do you follow the whole AI discussion just more generally outside the healthcare space? I think
the concern about Skynet,
doomsdayers. Look, my last podcast on this was, my guest was thought everyone was going to die from AI. Not yet. We're not at that point yet, but it was like a very much a doomsday conversation. And he lays out a pretty compelling case for like how that could happen if it's not somehow regulated properly and controlled. But where are you on that? You know, how do you think the federal government should look at it, regulate it? It is getting to a point where it can be quite terrifying.
Well, I have been, in disclosure, I have been rewatching Terminator, right? Because of this discussion.
Yeah, just have a healthy terrify.
I'm not really worried about Skynet.
Yeah,
actually,
maybe not Skynet, but something. I don't know.
Well, like humans are infinitely adaptable. We've shown that time and time again.
Yeah.
Right? Like we thought that the population of the world was going to be, we thought we were going to be overpopulated.
Yeah.
50 years ago. We've adapted.
Yeah.
To a changing environment. So I think even with technology going a new way, I think we will adapt.
I don't think Terminators are going to kill us all.
Yeah.
Right. I think this is interesting. This is how he laid it out. He's like, look, it's not so much the Terminators because who's going to build the damn things? But he's like, what a rogue AI machine could easily do once it's like smart enough and powerful enough, can hack through any system. All right, so it sets up a bank account, puts a lot of money in that bank account, gets in touch with some scientists, bribes the scientist, blackmails the scientist, makes them do. You're making humans do things to, I don't know, destroy the world, whatever it is, and boom, and that's how COVID-19 happened. I'm just kidding.
Yeah, no,
just joking. But imagine it's not that part. Those scenarios are not that crazy. With a rogue, malevolent AI machine, and then it's like the question of, well, what the hell creates a malevolent AI machine? What does that even mean? Will we ever get to that point where it views us as threats? Does that even make sense? I
think we're probably a long way from that. The technology is not going to be there for a long time. Your question, though, about regulation is a good one because the FDA, for better or for worse, for its device regulatory framework is stuck in the disco ball era, and that is
let's talk about FDA. The FDA really pisses me off.
Yeah, I mean, they have a shag carpeting disco ball era device regulatory framework that they're trying to regulate software with.
Yeah,
we gave them the wrong tools.
So okay, let's flesh that out a little bit. I mean, like some examples of some. So I have at least one example, right? Like early on in my podcast, one of my a friend from Houston on, she runs this company called Intuitap. Simplest device ever, right? It uses a sensor technology that's already used at normal FDA approval. And it just lines that up with basically a spinal injection, epidural needle. And just makes it so you hit the spot a heck of a lot more than you otherwise would just by trying to feel it with your fingers. This is years into the FDA process at this point. It just makes no sense to me. Are there other, do you see this, since you follow this issue quite closely?
I think it's a problem for software, right? So the FDA's regulatory framework for devices is built on, you develop your device, file an application, it's reviewed, and then you're cleared or you're approved, right? Like you have 510K clearance or a PMA, and you're approved on the market. And then if there's a change, you file either another 510K or a supplemental PMA and do that process again. Software, though, changes like every day.
Yeah.
If not every hour.
And software has to be approved. I think a lot of people are probably scratching their heads that software even has to be approved by the FDA.
It falls within their jurisdiction if it's for diagnosing and treating disease.
Okay, and so this is where the AI conversation gets interesting, right? Because now you're asking you're asking software to effectively diagnose, we haven't done that before, really.
No, we haven't. Right. And then there's the even scarier question of should it have a medical license?
Oh God.
Yeah, no, I don't think we want have the computer apply for a medical license. Right?
Well, that's what's so scary, though. It probably could and pass tests.
It might actually be better. I mean, there was a study in it was one of the JAMA journals recently. You know, the patient portal where you send messages to your doctor, and the doctor is like, I'm tired, I have 200 messages, and they send you sort of a grumpy reply telling you to go away occasionally, right? Like, the AI was actually more empathetic, was rated as more empathetic than the doctors. Yeah,
I read that, and as we were looking, I mean, because it doesn't get tired, right? It doesn't get like emotional exhaust. I mean,
but the principal problem remains, though, that the FDA is designed to look at something pre-market, put it on the market, and then leave it out there, which doesn't work with software.
I'm not even sure it works with their devices for one of the reasons the example I just gave is absurd. It's an absurd example. Any doctor can look at this thing and be like, this is obviously fine. This would be a useful tool. I don't even know. This is ridiculous to me that, and the FDA will rush to approve certain things that are high risk, but not this.
So what the FDA actually needs is they need a different framework, not a forced framework, like a voluntary alternative pathway to handle software. You could imagine you break it down into components, and the component either meets a consensus standard, undergoes testing in an accredited lab, or something that's simple, clear reference standard. Those components get then put together, and then the actual product gets reviewed by the FDA. And then that product, if approved, can become one of those building blocks.
Yeah, I think there's still an open question as to should they even be approving software. I understand it can be used for diagnosis, but it doesn't seem like we trust doctors a whole lot. Again, there's not a whole lot of difference conceptually for me between this conversation about software and my example on the device side, because in the end, the thing itself is very straightforward. This is what it does. It has limitations, right? Like the device that doesn't cure cancer.
Right.
Got it. But a doctor is still in charge of it. And so if a doctor is in charge, and so you either trust the doctor or you don't.
Well, I think software and AI in particular are different because it's not necessarily that the doctor is in charge of it. So software, and especially AI, can either augment that patient-physician relationship, supercharge it. In some senses, it can replace it.
Yeah. So what's the first step then? I mean, if we're going to start seeing companies come out with some really interesting stuff like you're talking about, what should we do? Maybe here or at the FDA, we can tell the FDA what to do. We don't do enough of that, I think.
Agreed.
There's a lot of reluctancy, but
I think
is it hiring the right people? Is it hiring the right reviewers? I mean, you kind of laid it out a second ago. Maybe flesh that out.
I would say creating a new pathway to review, the combination of hardware and software, right? Because it's not just software by itself, it's software overlaid on existing medical devices, making them more functional. Like the classic example is if you had diabetes, right? Like if you have diabetes, you have a continuous glucose monitor. You have an insulin pump, right?
Yeah.
You could, and it could auto-dose your insulin. Wouldn't it be great if that insulin pump and glucose monitor were hooked up to an iPhone app where you took a picture of your food and it carb counted for you, and then automatically dosed your insulin?
Yeah, that's not that far off.
No,
right?
it's not.
The companies make stuff similar to that, I think.
Components.
Yeah.
But we don't have a regulatory pathway for that.
Really?
No.
So this is, and therefore there's no incentive for somebody to put it all together, because they're like, the FDA is hard enough to deal with anyway, let alone with something way too new.
And so you'd have to do multiple 510Ks in a row, which is not efficient. The regulatory consultants like that because they can bill more fees.
Yeah.
But that's not good for the device developer, and it's certainly not good for the patient.
510K pathways.
The 510K is the clearance pathway.
Okay, for specialized devices.
For a device that's based on a predicate device.
Okay, all right.
So it's like an iterative improvement.
Okay, so you're improving upon something in the past that's it's in theory faster than going through this is a brand new thing, brand new idea sort of pathway.
So for that, you could do multiple 510Ks in a row for that combination of products, but that doesn't make sense, from a regulatory perspective, and it wastes the FDA's time too.
Yeah, I mean, it does seem to me that there's a lot of foundational problems with how the FDA does things. This just being one of many. I mean, this is the fact that they're not thinking ahead on a pathway for new and interesting software is more of a symptom of a larger broken system.
Right.
I'm just not hearing a lot of good things about dealing with the FDA from innovators. And Houston has a lot of that, right? And so I just don't hear good things. They're difficult to get a hold of. It's difficult to get guidance from them. You didn't like the way we did this. Well, how would you like us to do it? Oh, just different. You never know who we're talking to. They're not supposed to, but they what happens often is they're reviewers change, the reviewing teams change, and it's a specialist that has nothing to do with not even practicing medicine. Sometimes it's doctors who never practiced medicine. Right. There's like some real foundational problems with the FDA that I just like talking about in public because it just pisses me off.
No,
it's hurting people.
The valid critiques. I mean, I would say the first thing is that the FDA needs to return to the campus. Right, working a day a week on campus or a day every other week is not sufficient, right? Because if you're doing intellectual work, yes, some of it you can do at home in your office with the door closed, but a lot of it is like walking down the hall and asking someone a question. Yeah. Right? Like that spontaneous, like, I wonder about this. Yeah. Oh, there's this guy down the hall who has 30 years of experience. Yeah. Like I was a reviewer in the Center for Drug Evaluation and Research, and there was literally that guy down the hall. We bought him a seersucker jacket. We called him the Grand Mentor. Yeah. And like, if you had a question about the history or about something in the product space, you'd walk down the hall and ask him.
There's literally Terminators outside my freaking office right now. You could like it sounds like, I don't know, it doesn't sound that bad on the podcast. I don't think it's just a little bit. Luckily, these microphones work that way. But anyone listening, there's construction around the Capitol.
But back to your question about what the FDA could do and what we should do for the FDA is give them that pathway that is built on building blocks, and then those building blocks meet a standard, and then those building blocks, like the continuous glucose monitor, insulin pump, iPhone app that carbs counts and has programming to auto-dose your insulin, then that would undergo review by the reviewer. So don't waste their time like reviewing things that they've already know.
Yeah. I mean, it's going to be a difficult process, right? Because, okay, so what do you do? A clinical trial where you see if this program gets this diagnosis right this many times, I guess? Like, how would you even design that?
Well, part of that is making sure you have the right data set. Yeah. So there's a lot of concern about reliability and discrimination from software and AI, and the answer is, we'll have better data. No surprise, if you only test a software on Palo Alto, right, that doesn't represent the rest of the world. Yeah. Right? Like, you have to test in a diverse population.
Yeah, and then, but in control, but then who decides whether the AI was right? Especially if more complicated diagnostics where, if you bring 10 doctors in with a specific specialty, what's the chance they all agree on a diagnosis?
You probably get 12 opinions.
Yeah.
Maybe 14.
Yeah, I mean, exactly, right? So, because a lot of medicine is often problem solving. I mean, we're not even close to there yet, I guess, so it's not a problem to solve right now, but it is interesting to think about. We don't have that much time left, but what is your thoughts on, again, how government should look at AI more generally? There's been talk of like an AI regulatory agency. I think it's more important, frankly, that there's more of an international agreement on AI than there is. And I have some ideas myself, but how do you think about this?
I'd say regulated by use. Like, if you have, one, we don't need another regulatory agency, right? Like, that is probably the last thing we need, right? How many acronyms can I come up with?
But the director could be AI.
Yes,
that would just for the
and
irony
they could get
of
another
it.
building.
Yeah,
right. We could give them they wouldn't need a building.
It'd be the cloud. It'd be in the cloud.
Server farm.
Yeah.
But so it might be lower cost. But that aside, don't need a new agency. And also, if you create a new agency, it's going to usurp the existing agencies, right? So if this agency regulates healthcare AI use, is it the FDA or a new agency?
Yeah. Yeah, I think it's definitely a knee-jerk reaction, I think, by people who don't quite understand what we're dealing with. I mean, I think it does need to be sort of like most technology issues. You got to take a scalpel approach. Right. One of the things we talked about in the last podcast we did on AI, as I was just kind of thinking through it, and we were just having that conversation, was the digital watermark idea, right? So every product that is an AI product has to have a digital watermark. So it was AI. That's just a law, right? And you can break the law. People can still break the law, but the big companies, the ones with real strong AI platforms, they won't break that law. That would just at least solve certain problems, right? Like these deep fakes and tricking people, like the cons that can have, because it's not illegal to con somebody with AI, or is it? I don't know. I mean, I don't even know how would they prosecute that case?
In healthcare, it actually gets even messier, right? Yeah. It's like, one, who is liable if something goes wrong. Right. So liability depends upon how the product is designed and how it's used. Could be the manufacturer, could be the system that deploys it, like the health system, could be the doctor, Could be the patient.
Right.
Right.
Well, I mean, we have that problem now. Like, we haven't even solved that problem now. Let's go back to just using a doctor using a device. You know, how does that work in the medical practice? So you use a simple device, you misuse it, if
you misuse it, it's on you, the clinician.
Yeah, and how do you prove it?
Well, the patient's lawyer.
The patient's lawyer tries to
proves it for you, right?
Yeah.
When you get sued and you're in court for negligence.
Yeah. But there's common law. There's court precedent on this already. It could be applied to AI as well.
Yeah, and I think the other issue with AI is that we tend to, in healthcare settings, is we're like, oh, like the doctor and the patient need all the information about the AI, as if we're literally just going to like stop medical practice or stop clinical care in like an intensive care unit or in the operating room, be like, hold on, let's all stop and read a clinical trial right now. Like, that's clearly not going to happen.
Right.
And so, like, from a regulatory perspective, at least for our cognitive framing, we need to get to performance, right? Like, I drive a 25-year-old car. My 25-year-old car has like traction control and all these airbags and stuff still. I have no idea how the traction control works. Like, of course I don't. I'm an idiot. I'm not an engineer.
The wheels just spin at different rates.
But I know that if it's, I know if it's raining really hard in my rear-wheel drive car and I step on the gas too fast, like the traction control will kick in and perform.
Yeah,
performs within an expected range.
Yeah.
And that's, I think, the framing for thinking about AI regulation.
Like traction control.
Right. Think about performance. Regulation of performance.
Yeah.
Not regulation necessarily of the details.
Right. Like what is the outcome it's doing? Yeah, and at least I think you got to start with small ideas.
Right.
You know, it's also interesting that comes from these AI experts is that, you know, if you're worried about like the ultra supercomputer that can just do too much, I think everyone should be worried about that. There should be like Chinese worried, there should be Americans worried, there should be Russians worried about it. Everybody should be worried about that, and so there has to be some sort of like nuclear-esque agreement. And it turns out it is traceable. I mean, you know, the components necessary to do that kind of machine learning, the amount of power necessary, it's not nothing. It can't be done in a basement. Yet we're all. Yeah. I mean, but it would be a long time to the point or it could be done. From what I understand, from the people who know the computer nerd stuff. I don't know.
Again, I'm not an engineer, but think of how cell phones have changed in the past 30 years.
Right, but they still require a company like Apple to be able to build them.
That is true.
You know, like
I'll say that
you can't build a cell phone.
No, I cannot. But my cell phone is more powerful than the computer.
But these are two different conversations, right? These are two different conversations. If we wanted to stop Apple from building powerful cell phones, that would be something we could focus on. That it would be possible because you can't build that powerful cell phone in your basement. You just can't do it. Like you require a global supply chain, a multi-billion-dollar company, and AI, at least at this point, is like that. It does require serious infrastructure to build that machine.
To build the physical machine, but not the programming component.
Same thing. Yeah. Same thing because the physical machine is required to have the computing power for that program to create itself. And so that's what's interesting about AI. This is in my kind of research on my podcast, you know. But that's how, because I've asked these questions like, how does this even work? What the hell is it? Is it just some clever software program? And the answer is no. It's like a series of like a trillion numbers, and they all start at zero, and then it teaches itself how to manipulate those numbers just through data inputs until it becomes the machine that we deem is good enough, you know. And then, but you can keep adding factors, but you need computing power to do that. Now, once it's created, it can fit in your pocket. That's the scary part. Like ChatGPT obviously just fits on your cell phone, right? But it took a lot to create that.
Oh, yeah.
Yeah, and that's traceable. I mean, as far as a government is concerned. And so that's what's interesting about like the Doomsday Conversation.
And I would say part of sort of ameliorating the Doomsday Conversation is that as a country, we need to invest in the space.
Yeah, exactly. I mean, that's the thing. That's why it has to be an agreement, because we need to invest because the Chinese are investing.
Right, the Chinese are investing, and we want to win that race. We don't want them to.
So bring it back to healthcare in our few minutes left. I mean, so like, what's if you could just choose an aspect of healthcare where you would probably promote AI first, where would it be? Is there a specific kind of diagnostic or
I'd be
treatment?
much simpler. I'd be much simpler. I'd go back to the administrative stuff and say automating note taking. So that way the doctor can actually.
That's useful for
spend
all
time.
businesses.
Yeah, but it's so that way the doctor and the patient can actually have a conversation,
Right.
rather than the doctor turning into a secretary.
100%. That should be so easy. How is that not how is nobody making billions doing that right now?
Companies are working on it, but it's operationally not an easy thing to do.
Yeah. I guess maybe for the reasons we just talked about how to build AI, it isn't that easy. But yeah, that would be amazing, I'm sure, for doctors and patients alike. And so you think that's where it starts.
Yes, things like that, things like information gathering, teeing up that information for the patient and the physician, right? Like in the intensive care unit, instead of like wandering through Epic or Cerner to find all the important information you need, having it there in real time as a dashboard.
Yeah, that'd be nice.
And having that dashboard change as the patient changes. That's what AI can do.
Could it make our financing simpler? I mean, I think one of the biggest frustrations patients have with the healthcare system is just the networks and who my insurance provider is and what the copay. It's just massively confusing. What kind of insurance should I buy? If I even have that choice, how do
I mean, I agree. I think people usually don't ask about that, but it could definitely help on the financing side and on the operations of that financing side. Like, who is your network? What are the drugs on your formulary? Like, wouldn't it be nice if you went into the doctor's office and they prescribed something and then like you knew in real time for you with your insurance how much that would cost you?
Right.
Before you even left the exam room.
Yeah. Like little AI assistant on your healthcare. That would be nice. Hopefully that's what our doctor's offices and our healthcare experience seems like or looks like in, I don't know, 10 years? I don't think 10 years is that crazy, at least for those things.
I don't think it's crazy at all.
I think 5 years is probably
5 to 7.
Yeah, if that even.
If we create the space for it and embrace it.
I think the technology gets there in a year. I think the regulatory environment catches up in 30 years.
Yeah, and also I would say academic medicine needs to get out in front of it in a good way.
Yeah.
Because a lot of my, not necessarily colleagues at my home institution, but like in general in the medical community, they're afraid.
Well, and why? Just
loss of control.
Yeah. Fair enough. I mean, I see how doctors react when we talk about scope of practice. So this is like a big scope of practice issue.
This is huge.
And actually,
and the administrative stuff, like if we want prior authorization done timely, the computer's going to do it.
Yeah. Well, that would be a great place to start. That can't be that controversial.
It is, actually.
Oh, geez.
Someone's suing one of the health plans over that right now as we speak.
For doing
automated denial or approval of claims.
Huh. Does it not work well? Or
it's probably not been calibrated. Probably for certain hasn't been calibrated well.
Yeah.
But that doesn't mean that the principle is bad.
Yeah. It's a start because that's a big impediment for a lot.
A big impediment as a patient.
Procedures.
I mean, I do prior authorizations as a physician. I've been subject to them as a patient. They're a pain in the ass. Wouldn't it be great if we're more efficient?
Yeah. You have any other big ideas on healthcare reform, just generally, on how we do things?
Oh, there are plenty. I mean, I would say one of the things we need to do if you want to get really nerdy is improve the Medicare plan finder.
Okay.
You're like, what the hell?
Yeah.
The answer is
it's like Medicare Advantage plan finder?
Yeah. But the problem is you can't mix and match your benefits.
Huh.
So you qualify for Medicare. You go on, you can like pick fee for service. You can look up your MA plan. But you can't like get your fee for service, sub plan, and Part D. You can't compare.
You have to go to
one place.
You have to go to like different systems.
You have to go to different systems. The information.
I'm not 65 yet, so I haven't really looked into it.
Yeah, we're far away from it. The joke is that we have we care most about the Medicare program because we're so far from it, right?
Yeah.
Because we want to be there. But it's like, if that information isn't easily presented in a form that you can digest, how can you make a good decision as a consumer?
Yeah. Well, I feel that way about everything. Not just Medicare is a good place to start because we can kind of directly control that from Congress. Right. But when we look at direct primary care, finding your primary care doctor should be as easy as opening up your primary care app, like that everybody knows where to go. Same app for everybody, and you type in your zip code. And you see primary care, I like direct primary care, and you see what they charge on a monthly basis. You see why they're charging that, kind of what they offer, what their qualifications are. Simple shopping, and then boom, it's like signing up for a gym membership.
Right,
and it's that cheap.
You can buy a car, you can rent a hotel room, you can book a flight to New Zealand online. Like you can make those choices.
Right.
It's hard to make that choice with other things in healthcare.
Yeah, it's near possible. We're always trying to take bites out of an apple we can actually see and touch, and so that's why I focus on primary care. But you got to be able to have that choice and also education and clarity with your insurance model as well.
Absolutely.
Much tougher.
I would say another incremental win, and I say incremental in a good way, right? Because if we try and eat the entire apple pie, we're going to choke, right?
Yeah.
So it's like you're in your doctor's office, your doctor's sitting there, they're like typing, ordering a bunch of stuff. Wouldn't it be nice if they knew how much it cost?
Yeah. Oh, yeah. Crazy.
Like, we don't have that right now.
Yeah.
Like,
we're working. There's at least bipartisan outrage about lack of transparency. That's
but
the good news.
price transparency in the electronic health record, right? Because like a lot of the times you're at the doctor, they order an MRI.
Yeah.
You don't know how much that costs.
Yeah, and they order it from the person they always order it from.
Right.
They don't give you that like choice to compare prices.
Wouldn't that be nice?
It would be. How would you? Is that feasible? Is that
meaningful use?
Yeah. Is that
meaningful use, which is currently largely meaningless, could be made meaningful.
What is meaningful?
Meaningful use is the Office of National Coordinators Health IT. For Health IT, there are regulatory requirements for electronic health records.
Okay.
So we could do that through that.
You could
require price transparency. In the electronic health record at the point of service, which is actually interesting because the medical profession, if you asked them 30 years ago, they'd say, get out of town, that's unethical. But now, part of the medical profession's transformation, some of this is good, some of this is bad, is cost-effective medical care.
Interesting.
So they want to use your dollar effectively.
Yeah. Okay. So you could, in theory, require that as part of the electronic health record.
Absolutely.
I'd have to like see the electronic health record, I guess, to really understand how you mean that.
Right. Because like when the physician's ordering, they can order stuff, but there's no prices. So it's like going to the store and like checking. You're like, yeah, I'd like a Ferrari. I want to stay at the Ritz-Carlton. Yes, I'd like those chocolate truffles too.
Yeah.
Can I have a spa treatment, right? Like,
I
exaggerate,
but
there's no prices.
What does it look like when they order it, like quote unquote order it? I've never understood. I know my doctors do that,
right?
But it's usually within a hospital, so like they're, it's not like there's a choice, right? You're in that hospital.
No, but they could at least display an average price for the service.
Right.
Or a Medicare reference price or something.
And you could, in theory, put that into the health records so they order MRI.
Right. It says MRI of left arm, $712 on average.
Right. You could at least.
You could do that.
Yeah. That'd be nice. I think it keeps people in the game.
Yeah. And it like lets people know like what services they're consuming and how much they cost. Maybe not necessarily how much it costs them specifically, but order of magnitude.
All right. So in the short term, we can get, maybe some transparency on electronic health records, maybe some talk to text, and in 50 years we'll have space robots doing our assessments,
which would be great.
That would be great.
And I would say that they might be nicer. They might be nicer than us physicians.
Yeah, you could program them to be tough love, or depending on what you're into, tough love or not. It's really interesting. We probably have 1,000 more questions as we dive into these things and try to make the patient experience just a little bit better. So, thank you. Thanks for being on.
Thank you for having me.